I am a speech pathologist by trade. I have been a speech pathologist for 22 years. I have worked across the spectrum, across the continuum of care from pediatrics all the way through geriatrics. I've done acute rehab with peds and adults. Worked at Arkansas Children's Hospital. That was my first job right out of college and loved it. I had small children at the time, and having small children and working with same age children with all kinds of issues as far as brain injury and different traumatic events was more than I could wrap my mind around at that age. And so changed settings and have done a whole lot of different types of jobs, but I've been employed with Rehab Care and Kindred since 2001. So been with the company 16 years and really enjoy doing what I do. So part of that time, the last 7 years, was as a rehab director in Hot Springs, Arkansas, and that's where I live, is in Hot Springs. And, you know, in the setting as a therapist or a nurse, you are FIM scoring people, but you really may or may not really know about what the Earth Pie is and all the rules of it and that kind of thing. So this is to just give you a little bit more insight into how this all fits together when you FIM score. What does that mean exactly, as well as the accuracy of your scoring. All right, we're going to get started. So before you leave here tonight, these are the objectives of the things that we hope that you take away. And so the main thing is the burden of care. And so when you're assessing a patient and administering a FIM assignment for their task, you're certainly talking about the burden of care on a caregiver, whether that caregiver be a nurse, a therapist, or a family member when they go home. So that's the whole point of measuring the independence of that patient. You'll be able to score those FIM items and to know what an IRF is. That stands for Inpatient Rehab Facility Patient Assessment Instrument. That's the document that we transmit to Medicare at the conclusion of the patient's stay. And then you'll also understand how FIM scoring affects the available resources for your hospital and the patient's length of stay while they're here. So it really does define and determine a guideline for what their length of stay will be. And certainly you understand that if you see a patient on Monday and you see that same patient on Friday, the gain that they made in those 5 days many times can be the difference in whether they discharge to a skilled facility or if they discharge home. A few days makes a big difference when you're talking about acute rehab. And then you'll also understand what a case mix group is, or a CMG. It's a little bit different than the DRG that we hear about on the med-surg floor. So the prospective payment system was designed by CMS, and it just guides how we get paid for these patients, but it also guides a few more things. It's what we're based on for the length of stay, but if you think about the combination of those two things, if you keep a patient 5 to 7 more days, shouldn't you, because you're having to provide room and board, medications, and staff, shouldn't you get paid a little bit more for that patient? So that's how it works together. We do get a lump sum payment whenever we talk about case mix group. So when a patient comes in, based on where they fall, based on their diagnosis, it determines what case mix group they are in, and that's a lump sum payment. So if we keep the patient 5 days or 10 days or 12 days, if they discharge home, we get the same amount of payment. So many times if you're talking about discharge planning, you may talk to a patient and say, well, Mr. Smith, it's going to be next week before we talk about you going home. You're going to stay with us another week. And Mr. Smith might say something like, well, of course, you just want more money. But truly, that's not the case, and that, you can speak to that. No, actually, we want you to get better so you can be independent when you go home. Because truly, from a standpoint of wellness, that's what we want from our patients. Our programs are measured on progress of the patient and the quality that we put out, and that quality is measured by discharge to community, and that's what we're after. We want them to be able to discharge home. So the 5 components of a case mix group are the rehab impairment classification. That's what group of diagnoses we're going to put them in. Their admission motor score from the admit FIM, it's captured in the first 3 A's. And their comorbid conditions. Those are all the other existing disease-specific items that they're diagnosed with, their age, and their cognitive score. So now we're on slide 4, ways we use FIM data. So we've already talked about patient care and reimbursement, but what we haven't talked about is their progress in measuring change. So if they come in with an admission FIM of 65 and they leave with an admission FIM of 100, they've had a gain of 35 points. So it's a very measurable way of showing progress. And if we set their goals in each area, for eating, they came in as a 3, and our goal was a 6, and they left as a 6, they met their goal. So it measures goal attainment. But it also allows us to compare our program to other programs across the United States. So let's say you had a family member that was in another state, and let's say mom needed rehab, and you have a sister that lives in Arkansas, and you live here in Illinois, and you wanted to compare Anderson to another facility. You could go to CMS Compare, and you could compare the 2 facilities that you wanted to compare and see what their outcomes look like and which place would it be best for mom to go. So know that visibility and know that people are going on there and look, they're taking a look to see what the quality looks like. So we want that quality to be reflective of what we're actually doing for patients here. So on slide 5, we have what to score, and the FIM scores and the function modifier scores should reflect the patient's actual performance, not what they should be able to do, what they could do if they were at home. You'll hear that from the patient many times. Well, if I was at home, I could do that. But it's also not a simulation of the activity. So we had a discussion this morning about bathing, and yes, we do simulate the task as far as like tub shower transfers and that kind of thing. We simulate it in therapy, but if you score it, it should be actual. And so kind of in jest, we say that the patient should be wet and naked. So whenever you're doing something, it should be actual. It's okay to practice as a simulation, but not score. So the burden of care is the amount of assistance on a person or a device to be able to complete a task. And that's the question you're going to ask yourself over and over when you're FIMing. How much assistance does it take from another person or a device for this patient to do whatever task you're looking at? That was slide 6. I'm going to slide 7. So right now, Anderson's rehab unit, the average admission FIM is slightly over 70, which is around this line right here. And so this is a CMS chart, and it says that for someone that's admission FIM is a 72, we think that that should take about 168 minutes or 2 to 3 hours of care. That's all inclusive with therapy and nursing out of a 24-hour period. Do we believe that that is accurate at this point? Do your patients need more than 2 to 3 hours of care a day? Sure they do. And so it's our jobs to accurately capture how much time that they really do need. And that's how you do it, is with FIM. So it's important for a lot of reasons to reflect that. And so a lot of those I've already kind of gone over. Payment, progress, and it reflects the things that you're actually doing with your patient. So slide 8 shows scoring time frames, And so the IRF pie is broken down in two different ways. You've got your admission scores and your discharge scores, and then you have goals. So admission, you're looking at the first 3 calendar days. And it's the day of admission and the next 2 days. So if your patient rolls onto your unit, do you have a deadline for admission? No. So if they could roll on at 10 o'clock at night, let's say, day 1 is from 10 until midnight. So whenever they admit, whatever time that is until midnight is day 1. And then you have subsequent 2 and 3 that are calendar days. So in that time, you're assessing all of their subcategories: eating, bathing, grooming, dressing, all the way down. And you're taking the lowest score over that 3-day period. So in each category, and that's how we do the admission then. There are function modifiers, bowel and bladder, and I'm going to show those to you. And those are a 7-day assessment period. So you've got your 3 days that are your first 3 days on rehab, but then there's 4 days prior to rehab that you reflect. So on those 4 days prior, you're looking at the bowel and bladder accidents that occurred in those 4 days. Usually those are med-surg, but they may or may not be med-surg in this building. Could be that they come from another facility or come from home, another ER. There's a lot of sites that they could admit from. So in looking at these, I'm going to show you an IRF pie, and I want you to, so you can't see it really good up there. I'm going to zoom in. But what I want you to see before I do, so there's 2 sides. On the left, there's a side called function modifiers. And on the right, it says FIM instrument. On the left, this admission line is the scores, but it's not just true FIM. It's not just about independence. So the first level says bladder level of assistance. So that's basically like your regular FIM, or they min assist, mod assist, whatever. But the second line is completely something different. It's got a little key underneath it that talks about accidents. And so it says like a 7 is no accidents, all the way down to 5 or more accidents is a 1. So that is not FIM. Those are function modifiers, and there's a key that tells you the answer to that. So I'm going to zoom in on that so that you can see just a little bit better. Okay? So whenever you're looking at number 29 and 30 on the far left, person's bladder level of assistance may be a 6 as far as ability to control the bladder, as far as opening and closing so that they can urinate. But then they may have had more accidents, so maybe they had 2 accidents over the last 7 days, and that would put them at a 4. So if you scored that 30, number 30, a 4, but yet you're saying that number 29 is a 6, you have to go with the lower of the 2. So that's kind of some of the rationale behind things, that you really have to know exactly how many accidents they've had and what level of assistance they have.
Can I ask you a question?
Yes.
So if I'm scoring something that's not the IRF pie, if I'm just scoring my treatment for the day and they had an accident with me, let's say they didn't have an accident with me. I took them to the bathroom, or they went to the bathroom, they did really well, they got a 6. But in the last 24 hours, they have had an accident. So I have to score based off of my knowledge of them having an accident?
What I recommend is that you score what you see, and that if they have an accident, you document that in your documentation somewhere, so that anyone synthesizing documentation after the fact can count how many accidents actually occurred.
I have a question too.
Okay.
We've been told in the past that like an accident is actually like if they wear Depends or something, and if that's not an accident if they soil with Depends. But if they soil their clothes, then it is.
Correct.
But the burden of care is still high for somebody that has Depends and
Right.
changing them and everything. We've had a lot of patients that they don't go outside of their Depends, but there is a very high level of burden of care.
Completely get what you're saying. from a standpoint of CMS and how they devise and describe things, as long as it's contained within the brief or adult diaper or collection device, it is not considered an accident, even though it is implanted. So you're absolutely right. If it soils the linens or their clothing, it's considered an accident because that increases the burden of care.
So what if the person can change their own depends? That's a 7?
If they change their own defense, it's a 6 because they're using defense, but they're using them independently.
Right, but so if somebody need help changing their defense, then it's based off of how much assistance they need.
Based on the bladder alone, it would still be,
Sure. That's good.
yeah, you would capture the other with the transfer portion or, yeah. Everybody get that? So one of the first things you have to ask yourself when you have a question about FIM is, what am I scoring? So that would tell you what direction you need to go. And if you're using the little cards that are going around, whatever you're scoring has a separate card in itself, and so it can kind of help you with guidance on what you're looking at. But after we get finished with the slideshow, you're going to know a little bit more about how many parts of each task there are anyway. Okay, so one other point on this earth pile I want to point out is the distance walked and traveled in a wheelchair. So you've got number 35, 36, 37, 38 on the far left. And if you'll notice, you've got distance walked and then distance traveled in a wheelchair, and you've got distances coded underneath. So in that code, 35 and 36 say to get a 3, you have to walk 150 feet or more. To get a 2 is between 50 and 149 feet. And then for a 1, it's less than 50 feet. So you may say that a patient walked 50 feet with NIM assist because you're not having to put muscle behind it. You're only touching their gait belt when you're walking down the hallway. So if you say that, NIM assist, however, let's say they only walk 50 feet, so that makes them a 2 for that distance traveled level of assistance. So they're a 2 for the distance, and they're a 4 for the NIM assist, the level of assistance, but you have to take the lower between the two. So if you were to see that after you documented a 4, but you were to see a 2 somewhere, you would know that that's why it comes up as a 2. So at some point when we really dig deep into our documentation and you're answering questions for documentation, it may pop up an answer and you may look at it and think, what? But what I want you to remember is that's why it's popping up lower than what you answered. It's because of this distance. So you've got bowel, bladder, and distance that you're having to alter because of function modifiers. Those are the 3 areas that it's going to impact. All right, let's go back to the slides. So bowel and bladder have that look back period. And the FIM scores and modifier scores should be based on the best available information. Direct observation of what you see the patient do, but you can use credible reporting of a spouse or family member. Credible is the key. How do you know who's credible and who's not? You know, you really do. But I do coach my family members, like spouses, especially if they're going to shower a patient. I don't know what your regulations are here. Different facilities have differing recommended best practices for things such as showering. Most of the time they want a therapist in there or a nurse rather than just a family member. But sometimes as the patient progresses, it's appropriate for it just to be a family member. And so if that's the case, you want to coach them up and say, okay, there's 10 body parts in bathing. And I want you, these are the 10 body parts, and I want you to tell me which body parts he was able to wash after the shower is over. Okay? Usually they're pretty good with that. So then you come back and say, okay, we talked about you letting him do it as independently as possible. How many was he able to wash? So that's kind of the way the best practice flows. So you only report what you witnessed yourself unless it's a credible reporter, and then you can obtain that information from that person. So on slide 10, we have scoring guidelines. So it's very reasonable to have discrepancies from time to time in a single day or a single shift. After 2 hours, 3 hours of therapy, we're going to get fatigued. All of us would get fatigued, but if you can imagine coming in with a new diagnosis, being in acute care for a good 5-10 days before you come here, it's certainly going to wear on you. So in the morning, you may score a lot higher than you do 10 or 11 o'clock at night, and we FIM 24/7. So certainly there can be discrepancies, but I encourage you to have those conversations. So if there's more than a point difference, talk about it. Say, Mallory, I saw that you scored Miss Smith on transfers as a 4, and I've got her a total with 2 people transferring her. What are you seeing that I'm not? And then maybe Mallory can come and witness it herself and see, or maybe you're doing it a whole lot higher than someone else is documenting. It could just be the discrepancy because the patient changes due to fatigue, but it could also be maybe some verbal cues that somebody's given. Maybe they're coaching them up a certain way, and you've heard them. And I had her name was Betsy, she's a physical therapist. She weighed about 85 pounds soaking wet, and she could walk the biggest man down the hall with one finger because she just had the touch. She could coach them up, and she could tell them exactly what she wanted them to do and that kind of thing, and they did it. Good at verbal cues. So those discussions are key. There are times when the use of a 0 on the IRF pie may be appropriate, and so those are if the patient did not perform the activity, and if a helper did not perform the activity for the patient. The use of a 0 should be rare, but there are times where that is completely appropriate. Your documentation should reflect that. So R for refused. If the patient refuses a portion of your treatment, that should be in your documentation. 3 acceptable reasons are if it's unsafe for the patient to participate. Everything that I say today, you'll hear me say, do no harm. So if it makes good clinical sense not to do it for a specific reason because it potentially is harmful to a patient, don't do it. So we need a score. Well, so what? It's not safe for the patient. That always comes first, patient safety. As well as your own safety, because many times if it's not safe for the patient, it may not be safe for you. But request assistance if you need some help and you're not sure. Because our number one job is to get these patients home, and to do that, they've got to be independent. The second reason why you can score a 0 is if it's medically contraindicated. Certainly you wouldn't want to do something where a patient would need to put weight on something that was non-weight bearing. Just one example. And then if the patient refuses, you can score that 0. But you don't want to score anything 0 if the patient was not given an opportunity to participate. And there are a few items you cannot score 0. And those are bladder management, bowel management, and any of the cognitive items. They have to have a score of some sort. And you can't score 0 just because you didn't observe it. If you didn't observe it, leave it blank. It's different than a 0. So on this IRF 5, you've got 3 days, and we're capturing the lowest score from the first 3 days. So we've got all of those hours of data that are input that we're looking through to find the lowest. On this is slide 14. We've got discharge scores that we collect during discharge and 2 days prior. So in that, we're looking at 24-hour period of time. The first 3 days were just all together, lumped together in a pile, and we're taking the lowest score from each subsection of FIM. But in the discharge, we have to take a 24-hour period. It does not have to be a calendar day, like midnight to midnight, but it can be 7 p.m., one night to 7 p.m. the next. That's still a 24-hour period. And so what we're trying to capture then is we want the patient to be as independent as they possibly can be. So do you guys identify what day that's going to be? Do you have like Independence Day or Time to Shine or something like that? Have y'all ever done that? So a lot of our patients, like if they discharge on Friday's their discharge day, then we'll identify the day prior to discharge, the whole day, as Independence Day or Time to Shine. We'll put a little magnet outside their door. We'll give them a fluorescent t-shirt that says Time to Shine. And so that's the indication to everybody in the unit that you got to make them do everything they can independently as possible. That way we're trying to get the best score and the best set of improvement documentation that we can. So that's kind of the whole point in doing that is it's a physical and visual reminder to everybody that walks in that door it's their time to shine. So just helpful hints. Some people use buttons, but it's certainly good stuff. So you've already seen the earth pie. This is just basic FIM 101. So that's that white sheet that I showed y'all on those flip cards. So earlier today they said you guys did have some flip cards around. So where are they located? Anybody here know? Nurse's station or therapy documentation? You have seen them? Okay. So if we need more, we can order more. We just need to know like kind of how many we need. So on that white card, it's got all of these. And so why is this important? So the top two, 7 and 6, is no helper at all. So if you're a 7, you do everything independently, timely, and safely. If you're 6, you may need the assistance of a device of some sort. Some of those are dentures, glasses, medications, reacher, sock aid, shoehorn, you know, the whole gamut, durable medical equipment. If you need a helper, a physical person helper is a 5 or lower. Supervision means that you don't touch the patient. You can cue them, you can coax them, you can set things up for them, but you can't touch them at that level. If they're a forward, that's min assist, you touch, but you only touch. You're not activating a lot of strength or muscle to do anything with them in that category. And then if you are activating muscles to either pull up or ease down or something like that, that would be mod assist. Anytime it takes more than one person, it's a total assist, and so that would be a 1. It's just a rule of thumb, kind of generic way of looking at them. So this is the breakdown of that. And that's slide 17 tells about what it takes to be a 7 for complete independence, a 6 for modified independence. It's when you're using a device or aid. If it reasonable amount of time, what is reasonable? So the definition is more than 3 times the usual amount of time to take to do a task. So some of those things you just have to use your professional judgment on. You know those folks that eat, and you know most people are done in about 20 minutes. An hour later, they're still not finished eating. That would be something to score down on eating. And then if there's safety or risk involved in whatever their category is that you're scoring. So setup and supervision. Anytime when you take the test, the credentialing test, if you see the word setup or supervision, they say it in a million different obscure ways in the test. But if it means setup or supervision, you know it's at least a 5 or lower, okay? So the first thing I tell my folks to do is look and see what you're testing. See if you see the word supervision or setup. And then look and say, do I have to touch them? Did it involve touch? So that kind of whittles away at the layers that you are looking for in scoring. And then total, 2 people or more. The percentages are important. 25 to 49% is always max assist. It doesn't matter if you're scoring bathing, grooming, comprehension, cognition, it's all the same. It's levelized, standardized. Function modifiers, we've already talked about that in depth. So now I'm on slide 21, bowel and bladder management. You've got the level of assistance and the frequency of accidents. This speaks to your question about the difference between accidents and incontinence. Wetting of linen or clothing is key. Slide 22, we talk about the level of assistance and that you cannot use a zero. If you have a patient that's on dialysis and they do not void at all because of renal failure and they get dialyzed, they score that as a 7. And so a lot of people would say, a 7, why is that a 7? They're going to dialysis. It's all about the burden of care on the caregiver. So you're not taking someone to the toilet to urinate, you're not changing their linens. There's really no burden of care on you as a caregiver if they are on dialysis. The way we capture the dialysis portion is through the dialysis codes that we put on their IRF. We've talked about the function modifiers and how you have to take the lower of the two based on the accidents. And then the accidents, you're not FIMing that. It's got codes underneath it. You're just putting it exactly in the category that goes in based on accidents. That is slide 23. And now in 24, we're going to talk about level of assistance and what is considered to be a 7 for bladder level of assistance. Never incontinent, controls their bladder, and does not take medication for bladder control. So if you got somebody that's on like Detrol or one of the urgency frequency meds for urination, that's going to make them a 6. That is an aid. Same thing with bowel. If you've got someone that's on a stool softener, any of those meds, that's going to make them a 6. Laxative, milk mag, any of that stuff. For the bladder level of assistance, if they use medication for control, they're a 6. If they're using a catheter, a bedpan, any sort of collection device, they're a 6. If they're self-cathing and they're taking care of all of their own tasks, and then they can be a 6. If you have to bring them the supplies, then it's a 5. But as long as you're not touching them, it's 5 or above. If the patient uses the device and they apply it to themselves and they urinate and then they go pour it out and clean it up, it's a 6. But who would do that really? If they use a urinal, for example, most of the time we see that as a 5. Because typically they are using it and setting it at bedside, and then we go and empty it and clean it up. So these are just level of assistance scoring hints. If they require assistance with the application of an external catheter, but they do the rest, then it's a 4. It just captures the fact that you had to assist them with that as far as touch. If you only had to do one of several tasks, it would be a 4. Do you guys do timed voiding programs here? Okay. So do you leave that up to the patient to call you every 2 hours to say, hey, it's time for me to go to the bathroom? No. So typically what happens is, it's 2 hours, I'm here, it's time to go to the bathroom, right? So they want you to put the onus of that on the patient, not on yourself. If you're responsible for that, then burden of care, right? You're responsible. So it says on time voiding programs where the patient is dependent on staff to implement the program, it would be a 1. So see what you can do to put that on the patient. See if they can remember. If they can't, you know you're going to have to. But do it as a trial. We talked about the scoring for urinal use on page 27. Level 6, they retrieve the urinal and empty it. 5, the urinal is set up or emptied by helper. And 4 is if you have to help them by placing the urinal. Frequency of accidents, we've discussed this at length. It's not a FIM, it is a modifier or a code, okay? You just follow the key based on how many accidents, and that's how you code it. The bowel level of assistance, it mirrors the bladder, so it's exactly the same scoring system and everything. And you can tell that it's the same verbiage. So on level 6, this is if the patient requires a bedpan, bedside commode, laxative stool softeners, all those meds count, okay? I wanted to go over the colostomy. If a patient comes in with a colostomy and they maintain it, it's still a 6. But they must maintain it. So that includes emptying, cleaning, the whole bit. Usually in the beginning, they're probably too weak to do that, but usually by discharge, they should be able to do that themselves if that was something they needed prior level of function. Yes, ma'am?
What about a probiotic?
I would say no on a probiotic, that it wouldn't be counted as a, even though in a lot of people it does affect their bowel, it can be used for a lot of other things. So I'd say no on that. There's also some drugs that I'll talk about in a minute, of like social interaction is one of the things we score if somebody's on an depressant or anti-anxiety med. That counts a lot of times towards the social interaction. However, there are some people that are on some of those meds that have 2 different reasons for giving it or more. Peripheral neuropathy causes pain in the extremities, and some of those antidepressant medications relieve some of that pain. So you got to look at the rationale of why they're on what they're on. Suppository scoring hints. If the patient self-inserts the suppository, it's a 6. Earlier today, someone said, does that really happen? And it really does. If you or I were in the hospital in our current functional state and we couldn't go to the bathroom, that would be an option. You could self-insert the suppository. Certainly different policies and different facilities are different, but I would guess that if the patient's physically able, that they would be able to administer that themselves. If you have to set up the supplies, go and get the pad and cleaning supplies and that kind of thing, it'd be a 5. But if you have to position or place the suppository yourself, it would be a 1. Cognitive domain, so all of the communication, cognition, expression, all of those things, people get a little antsy about. So I'm going to try to set your mind at ease on scoring these. This is slide number 33. These items are assessed across all environments 24 hours a day. So your score, I'll speak for myself, my score if you scored me at midnight would not be as good as it is at about 6 a.m. Be a little grumpy and not thinking as clearly and that kind of thing. So that's expected. It's important to get a picture of the patient. I say paint the picture. Comprehension is complex and abstract, and it could be basic needs as well as conversation and directions. And then expression takes into account how you're able to express complex, abstract, or basic needs. And so we cannot use 0 for the cognitive items. So you want to think about patients. You know the ones I'm talking about. Either they're talking about basic needs, like they need to go to the bathroom, they're hurting, they are hungry, those kind of basic needs. Or they could be talking about religion, politics, discharge planning, what am I going to do when I get home, who's taking care of my dog, you know, those kind of things. Where am I going to live? So there are certainly some things that are beyond the physical here and now. If they can think about those things, they're a little bit higher functioning. So on slide 36, with comprehension, you're going to talk about whether the patient is comprehending messages presented auditorily or verbally. Auditory or visual, sorry. And if they understand in their usual language. So certainly if someone, do you get many non-English speakers here? Not really? Okay. If you were to get a non-native English speaker, then you would need to present all of these in their native language with, there's a lot of different interpreter services, like the phone, there's a phone line you can call in and they'll interpret for you. But you would need to put this in their own language. If you're scoring them, their most frequent mode of communication, it would be auditory or visual or both. A lot of our patients are both. But let's say you had a low vision patient, your low vision patient would be high on auditory and vice versa. If they're hard of hearing, they're going to be better with vision. Sometimes they're low vision and low hearing, and so then it's kind of a toss-up. So whenever you're looking at scoring this comprehension, it's important to first determine, are they complex or abstract, and then determine basic daily needs. Which are they communicating? Are they able to talk about things that aren't tangibly there? If they are, then you know that they're going to be kind of on the upper end of the spectrum. If they're not, then you know they're towards the bottom. So that's the first question. Complex, abstract, basic daily needs, which one? The second question you're going to say is, okay, comprehension. Can they understand directions 50% of the time? Half. You should be able to kind of come to a conclusion. Is that answer yes or no? If they can do it half the time, then you know that number 3 is your starting point. So half the time, 50 to 74%. Then from there, you're going to say, okay, if I'm with them, if you're a therapist and you're with them for 45 minutes or an hour, think about your hour. You're not talking about the whole day, you're just talking about that hour. Out of that hour, how much of 1 hour were they able to really follow instructions whenever you were visiting with them? So that should give you a little bit of feedback. It makes it a little bit more measurable. So if you had them for an hour and you think 30 minutes or half the time, then you're going to go with that 3. If you think it was better than half, you're going to bump it up to a 4. Yes, ma'am.
What if, yesterday this happened to me, I had a patient who I know understood everything I said, but I either mumbled or she couldn't hear it. So half the time she was going, what's that? What'd you say? So is that just hard of hearing? Is that?
Well, and it certainly interfered a little bit. When you think about burden of care, you've got to reflect it somewhere, right?
Sure.
Yeah, absolutely. So in looking at this, like on number 6, it says patient may require hearing and visual aids or assistive device. So do you know if she has hearing aids?
Mm-mm. She did not.
Okay. So certainly that is indeed where you would reflect that is in this category. But if you have a question about whether you think that sometimes they mask very well. If they need more time, especially our stroke patients, mild dementia patients will do that too. They'll just kind of prolong it. It gives them a little bit longer to think about what the answer is. So to answer your question, this is the category that you would bump down. Number 38, expression. This is a partner or a mirror to comprehension. Just talking about what you can verbally or non-verbally express. So another question earlier today was, what if somebody is really good at gesturing? And we have a lot of our expressive aphasians that really are good at this. So they may well be able to place your aids with you and act it out, and you understand everything that they're attempting to express to you. So it's about the percentage of the message that you're able to understand, not about necessarily how it's presented, other than indicating are they vocal or non-vocal. So you do need to indicate that portion, or both. Sometimes it's both. And the reason I say that this mirrors, if you look at it, is exactly the same thing we just looked at. It's just about the expression of it. So you've got complex abstract, and you've got basic daily needs. You've got the 50 to 74% is the 3. Is it better than half? Is it worse than half? And so the bottom end of this is less than 25% is where it would be basic. Social interaction. So you've got patients that are in the therapy gym or a day room at mealtime, and they haven't seen each other in about 15 years. They used to work together at the sawmill in town, and so they're sitting over in the corner as two gentlemen, and they're telling a joke. You're in the room, but you're kind of off at the other end, and there's some foul language involved in the joke, but they're not really being loud or disruptive, but you hear what they're saying. And they both laugh, and they think it's funny. So would you score off on loud, foul, or abusive language? No. Because for social appropriateness, that is appropriate for two people that have known each other for a long time to share something that they feel like is funny, you know. So consider the circumstance is kind of the takeaway from that story. Also, you know, you call down or redirect those people that are very disruptive, but then you have people that are shy to themselves, depressed, require encouragement. Those people also, their scores should reflect it here as well. So that part's important to do. If you have to redirect someone or provide encouragement to participate in tasks pretty frequently, then that should be reflected in the score. So when redirection is needed for whatever reason, it's no higher than a 5. And so this is the spot where we talked about antidepressants and anti-anxiety meds. And if they're on either of those, then they would be no higher than a 6. So social interaction, a 5 is maybe they just need supervision under stressful circumstances. Some of our brain injury folks don't handle transition very well. So they might need a little extra TLC in transition time if they're going from one space to another. But then the percentages are very, very important. If you have a person, a patient who is one of those that you have to call a sitter for because they keep getting up out of bed, and that you might tell them five or six times, stay in there. If you need something, hit your button, and you look up and there they are in the hallway. Part of that's memory, but part very well could be social interaction. Problem solving. You really want to think about the 2 levels problem solving too. Like just recognizing that there is a problem is a big thing for a lot of our patients that are stroke or brain injury. Also some that have mild cognitive factors, whether it be mild dementia or if it's a result of status post anesthesia from from surgery. So those are important as well. So on slide 45, we've got complex problem-solving examples, so managing a checking account, participating in discharge plans, self-administration of medications. So let's talk about self-administration of medications. This has been listed in research, current research, as the #1 reason patients readmit to the hospital. That's important because we don't want them readmitting. We want them to be home. So one of the reasons why I believe that that's a contributing factor is most of our hospitals across the country, on date of discharge, the doctor comes in and he writes his discharge med-rec, along with his discharge summary and that kind of thing. And so then the nurse calls in the prescriptions to the pharmacy and goes into the patient and says, the doctor ordered these meds for you, and the patient in their mind, it's like, like Charlie Brown's teacher. And so all they're thinking about is, when can I go home? Who's bringing me home? What time am I going to get to go? How soon is it going to be? I mean, it's just constantly, you know these people. And so you've got this list, and they're not really hearing you. They're not hearing what they need to take, what's new, what's old. They go home and they go back to their prior scheduled meds, and that's all they have. They may pick them up and just not take it, and maybe they don't know what it's for. So it's very important, especially for our folks that have difficulty with problem solving, that process start at team conference and proceed until discharge. So involve your OT and your speech in the process of them being able to distribute their meds and know what to take when. Very, very important. So those are complex problem solving. basic routine problem solving, like I said, you need to think about, do they recognize there's a problem? So until this point, you may be thinking assigning a FIM is at the end of my session or at the end of my day. Think back to all the things that people did and I score them. That's one way to look at it. That's a reactive way. But a proactive way is to set up your situation so that you manipulate the environment of that patient to get a score, to get their best score. If they're a 3, how do I get them to a 4? What do I need to do? What are the steps that they need to do to get to a 4, and what can I do to get them there? That's kind of the next level of thinking that really is beneficial for your patient. So on this, let's say you are helping to pass trays, and you steal the silverware off of the tray, and you set the tray down in front of the patient. And you say, you need help with anything? And the patient says, no, I'm good. So then you walk around, and you're passing out other trays, and you're continuing to look at Mr. Smith sitting there with no silverware, until he begins to kind of pilfer around on his tray. And you see he's kind of searching, but he didn't say anything. And so you check back on him. Mr. Smith, everything okay? Yeah. So you wait until he identifies what the issue is and if there is a problem, and request assistance. Now certainly you wouldn't let that go on forever, but you're setting up so that he will have a reason to initiate. So there are a lot of things like that you can set up, and so that's just a different way of looking at them. It really is like the therapy. When you get to that level where you're setting up the environment, you're really implementing rehab goals. So if they request assistance before they transfer, if they do things in the right order, do they unbutton their shirt before they try to put it on? Sometimes they'll just pull it on even though it's got buttons all the way down. So making appropriate decisions, readjusting to change, sometimes that's hard, carrying out a sequence of steps. I asked my speech people earlier today, I'm like, all my SLPs out here, do you get orders on patients every time a new patient comes? They're like, no. Well, that's not unusual because, if it's an ortho patient, usually they don't need speech, right? But typically speech is kind of in a lag because if it's a patient you wouldn't typically expect, if it's not a swallowing patient or a stroke patient, you get those referrals from OT and PT because they say, they need you bad. They can't follow directions at all. But sometimes it takes a few times. Evaluation, it's like, I tell you what to do, you do it. That kind of exchange. You're not really having to watch them process a whole lot as much as you do in subsequent days. Yes?
I did have a question on like what you were talking about with the problem solving and setting up trays and stuff like that. A lot of times the trays that we get here, say if a patient got a carton of milk or a juice container, they can be difficult even for us to open.
Right.
Does that count as part of setup necessarily? Because they can be difficult for us.
Right.
Especially like the mustard packets and stuff like that. We have to go cut them open.
So CMS talks about as like restaurant service. That's how they want you to compare their meal. So at a restaurant, we do get sealed packages of silverware at KFC or Taco Bell or whatever. We do get sealed mustards at Sonic or, So fast food, we see those things. But at a sit-down restaurant, normally we have bottles that you take the top off and squirt out and that kind of thing. So probably as a system, you guys need to talk about some of those things. At my rehab in Hot Springs, I got bottles of ketchup and mustard, and we kept them in the refrigerator, dated them, and got those out for mealtime. But the reason we do the individual is just for sanitary purposes, and it's just for germ control. So if you're having to do it for them, I would consider it set up.
What if they figure out, hey, I can't open this, and they say to you, can I get like a scissors or something to open this up? Would that be an appropriate like independence or problem solving?
I think that it would, as long as you knew that they would be safe with scissors.
Sure.
Yeah. But the little Fisker scissors, like, that still cut, not the kindergarten safety scissors, but I think that'd be great, because all of us, that's probably what we would do at home. Yeah. And just to score it accordingly. But that would be the problem solving right there. They recognize the problem, they have a potential solution, and it's not something that's visible right there in front of them, so that would increase it for sure. All right, any questions on problem solving? Back to the, if there's someone that may need one-to-one direction to complete simple daily activities, that would be your bottom, your one. Or if it's somebody that there would be a consideration or a thought that they may need restraints. Most of our rehab units are restraint-free. So, certainly that wouldn't be a consideration, but if it's one that you're having to get a sitter for one-on-one, you need to reflect it in problem solving as well. Memory, we talk about the patient recognizing people frequently encountered, remembering daily routines, and executing requests. The 3 R's of memory. So they may not remember that you are a therapist or a nurse if you walk in the room with scrubs on. But if it's a routine that's set up, if it's just before lunch, just before breakfast, you've been in the last 2 days at 7:45, and you come in with your cow, and you've got your little cup, they should know that you're there for bed pass. So that's important. So if they can recognize, remember, and execute requests, they're a 7. If they have mild difficulty, they're a 6. They may need environmental cues or prompts, and if you have to prompt them, or if they have visual aids, then it would be a 6. Some of our folks use memory books or memory strategies on their board. That would be the 6s. If you have to prompt them only during stressful or new situations, it's a 5. And then you go back to your percentages. Half the time, less than half, more than half. On slide 53, we've got eating. And this is where we're going to start the concrete portion of everything, okay? So eating has 3 parts. It is scooping the food onto a utensil, bringing it to your mouth, chewing and swallowing. Basic 3 parts to eating. All of these are different ways you can assist with eating. If you have any of these things, it would make it a 6. If you have thickened liquids or mechanically altered foods, texturized foods, then it's a 6. And you need to take into account their nutritional and hydrational needs. So if they're dehydrated and they're on an IV, you need to consider that. So setup includes opening containers, cutting up meat, buttering bread, pouring liquids. I do encourage you to say to the patient, I told them earlier today, I had an aide who was a little bit gruff, and she said, we can't do all that stuff for you, you got to do it yourself. And I said, well, a nicer way to say that might be, we want you to be independent, so when you go home, you can take care of yourself. We'll help you with it, but I want you to try it yourself first. So certainly let them do it themselves, encourage them to do it themselves first. If you have to supervise the meal for speed of eating or portion size, it's a 5. But if you're having to check for pocketing in their mouth and, if you're touching and looking, then that's a 4. And if the patient receives 2 feedings and the helper does the administration of those feedings, it's a 1. Dentures are considered to be assistive devices, but only if the patient needs that to eat. Some of our patients, it's cosmetic. Dentures are cosmetic, and when it comes time to eat, they put them in the little dish and they eat without them. So 3 parts. 3 is the denominator, and you can divide however many they can do by 3. Any questions on eating? All right. Remember that safety is what makes it a 6. You may have adaptive equipment. If a patient relies on alternative needs of nutrition, like G2 feedings, and they do the feedings themselves, it can be a 6. So on page 60, we've got the eating scenario. Samantha's on a feeding tube. After the nurse sets up the equipment, Samantha independently administers her tube feeding. What's her FIM score? I've got 5, and I've heard a 6. What else? It is 5. Good, good. So something I tell everybody when you start taking that test, there are a million ways to say set up. But if it says sets up, set up, supervision, but then they say it other ways. I'll show you some examples later. So grooming, there's 3 parts in eating, right? Well, there's 4 in grooming. Oral care, hair grooming, washing the hands, washing the face, but it's not just washing, it's washing, rinsing, and drying. Okay, so occasionally frequently you have a gentleman who shaves every day, or a lady who puts on makeup, and they don't want to leave the room till they put on their makeup. So then that would make it 5 parts of the task if they either do makeup or shave. But you will have a patient some patients will shave and apply makeup. If they must shave and apply makeup, then that would be 6 parts of the task. Okay? So grooming, it does not include flossing their teeth, shampooing their hair, applying deodorant, or shaving their legs. Now, can you do that in grooming task if that's something they need or want to do? Yes. It just does not factor into the FIM. So for a level 7, they can do all of these tasks independently with no assistive device. At a 5, they require supervision or setup. They may need assistance with the application of orthosis or adaptive equipment. They may need help setting out equipment or initial preparation. And then grooming is just the number of parts of the task and how many they can do independently. So 3 parts in eating, 4 parts in grooming, maybe 5, rarely 6, but it happens. Bathing, how many parts are in bathing? 10 body parts. So they must wash, rinse, and dry all 10 body parts. This is slide 67. So the task can be performed in a tub or a shower. Usually your OT decides whether they're going to be a tub or shower, depending on what they have at home. And if a patient must use a handheld shower, that's an adaptive piece of equipment. So if that's just what they have at home, it's not adaptive. It's just if that's what they have to have. So if a patient needs help with setup, setting out all their bathing equipment, then you're going to count that as a 5. So these are the 10 body parts that you're going to count. The arms are 1 point each. The legs are 2 points each because it's harder for them to wash their lower legs and feet. So 2, 4, 5, 6. So your extremities count for 6. And then you've got your chest and abdomen, 7, 8, perineal area, and bottom, 19. So here's your scenario for bathing. Tony suffered a stroke and tried hard with each activity he's asked to perform. After a helper sets up Tony's supplies for bathing and puts a wash mitt on Tony's left hand, Tony washes, rinses, and dries his arm, chest, abdomen, and perineal area. The helper completes the rest of the bathing task. What's his FIM rating for bathing? Think about it for just a minute. So what are we scoring?
How many parts?
Right. So we're scoring bathing and we're looking at how many parts. Is there anything that says set up or supervision? Yeah, so you know that it's 5 or lower at this point. Did anybody touch him? So it's down to 4. And how many body parts was he able to do versus how many there are? So we know there's 10, so out of 10, how many could he do? Arm, chest, abdomen, perineal area, 4, right? So that means the burden of care on someone else was 6, and he did 4. So that's 40%. Back to that original little card. Are my cards still out there? Yeah, look on the white sheet. What does it say 40% is? There you go.
25 to 49.
That's what it is, too. So that's the way you attack any of the processes. Upper body dressing. So this can be dressing or undressing, okay? So we call that reverse ADLs whenever you're looking at it backwards. OTs have said that for years. Speech, relatively new concept. I don't know about PT, but so this is applying or removing a prosthetic or orthosis. We need to let the patient obtain the clothing from the dresser or closet. Many times we go get it, set it out. We don't give them the opportunity to get that for themselves. So if you go get it, set it out, you're not giving them a chance to be anything higher than a 5. And we want them to be as high as they can be. So assess how they can go and get their things. You're only going to score if it's street legal. So if something you can wear to town. Earlier I said, we're not talking about Walmart. Have you seen those videos? They're hysterical. So we want you to score not a nightgown, but something that has pants and a top. In rare occasions, I've been known to use scrubs, but I don't like to do that. I had a deal with my local Goodwill. It was right up the road from us, and so they would give us clothing in whatever size that we needed, and we would utilize that clothing. At the conclusion, we would either send it home with the patient if they needed it, or we would donate it back to Goodwill. So it alleviated the need for storage, and it was a good working relationship with another agency in town, so that was great. So if they need assistance with obtaining clothing, then that's setup, that's 5. Applying or removing prosthetics, that's a setup, a 5. Or managing shirts, sweaters, bras, zippers, or buttons. All those things are things that they might require assistance with. So upper body dressing. If it's a lady and she wears a bra, then you're going to talk about how many parts that is. And so here it says a bra has 3 components. That's not always true. It depends on how you put it on and what kind of bra it is. So every lady puts on a bra a little bit differently. If you wear a sports bra, you put your arms in, your head in, you pull it down like you would a pullover. Some ladies put their bra on forward facing and fasten it in the back. Some fasten it and twist it around and pull it up. So you just count the steps in how they put it on. You need to ask the patient. We have some ladies that reached a certain age and said, I'm not wearing that anymore. And so if they don't wear it, you don't count it. So you add up the number of components and divide it by the completed components. Let them obtain it from the drawers or closets. If they require special adaptive closures, then you're going to only score them at the highest of 6. But make sure that it's required for that patient, not just something that they happen to have. Another mirror image is this lower body dressing. It mirrors upper body dressing. The difference is, remember that pants, if they don't have buttons or zippers, you know, you're gonna have less parts than if they do. So the difference between, they call them trousers versus pull-up pants. Putting on and taking off scrubs occasionally is okay, but try not to get reliant on that. Talks about lower limb prosthesis. If it's applied by the patient and the patient does not use it as a device with dressing, then no other assistance is needed. It's a 7. On slide 77, we've got lower body dressing. As with upper body dressing, the scores are obtained letting them get it out of the customary area. They say if you say something 7 times, that's like the magic number, so that's my hope. But let them get their own clothes. If a patient dresses himself while standing and only requires steadying assistance, remember that's no muscle, that's just your hand on their back or shoulder or whatever, so they don't fall over, then that is a 4 because it did require your touch. It required your burden of care to be there. If they require assistance to put on anti-embolic stockings, compression stockings, they can score no higher than a 5. Okay, do you have to touch somebody to put on TED hose? Absolutely. But this is the one freebie. Any medical equipment that you apply to a patient only counts as setup. 5. You're touching them all right, but it's medical, it's setup. Just remember that. Lower body dressing. Number of components divided by the number that they can do themselves. Shoes and socks have the same 2 components. Put on one shoe and sock, put on the other shoe and sock. So it's just like half. A point each, basically. So lower body dressing scenario. Samantha wears pants, stockings, and slip-on shoes. A helper applies Samantha's stockings. Samantha threads both legs into her pants using her walker for balance. She pulls up her pants. Samantha slips on her shoes while she sits in a chair. What is her FIM score for lower body dressing? So, what's our category we're scoring? Lower body dressings. And so, I underline it up there, but on the test, they don't underline it. And so, and they throw in all of these things that are extraneous that have absolutely nothing to do with lower body dressing. So you got to know what parts of your task. So does it say setup or supervision anywhere? No. Does it say anything about anybody touching her? Yes, it does. So what's the highest she can be? If somebody touches her, what's the highest she can be? 4. All right, so how many parts? She's got pants, and it doesn't say anything about any fasteners, so how many parts is putting on pants? Y'all count that as 3 per pant? Okay, so 3. And she's able to do all 3 of those, right? 3 out of 3. She slips on her shoes while she sits in a chair, so that's 2 more, and she did that by herself. What does it say about her stockings? Somebody helped her apply those stockings, right? So that'd be 2. They helped her put it on, 2. So she was able to do 5 out of 7, right? So what's 5 out of 7?
So stockings are different from compression hose?
Yes. So on the UDS credentialing test, they're calling stockings any kind of foot covering. Socks, pantyhose, whatever you want to call it, or stockings. It will say anti-embolic stockings if it means TED hose. Okay? All right. It does have it as a 3. Lower body dressing again. Now it says, Hope wears anti-embolic stockings, pants, and shoes. Using adaptive equipment, which means it can be no higher than a 6 if it's adaptive equipment. She slips both of her legs into her pants and pulls them up to the top of her legs. While she turns on her side, from side to side in the bed, a helper pulls her pants up. The helper applies her stockings and her shoes. What's her FIM rating for lower body dressing? That's a little tougher. I'll let you think about it for a second. All right, did she require touch?
Yes.
Yes, so we know we're gonna start at 4 and work our way down. All right, so the pants, in this case, I think it would be a good idea to consider it 4 parts. And I think that that's completely okay to consider it 4 parts. Because she was able to do each leg and pull it up to her, it just says to the top of her legs, so we're guessing that's thighs. But then the burden is on someone to help her pull them up. So if you said she could do 3 out of 4 for the pants, and then the helper applies the stockings, and those are anti-embolic, which means 5. So we're already below that, so that's not an issue. And her shoes, but so it doesn't say anything about socks either. Sometimes people wear Ted hose and socks. Doesn't say that. It just says stockings. So they're vague. So you're looking at 0 out of 2 for shoes, plus 3 out of 4 for pants. So you're at 3 out of what? Let's see, 6. That's 50%. So what does 50% convert to?
3.
So many times they also, they're tricky about these stockings. This is actually one we've sent to CMS for them to give us clarification on. Because it doesn't, underneath the helper applies hope stockings, it doesn't say anti-embolic, but it does say at the beginning that this is anti-embolic stockings. It gives you that she wears stockings, pants, and shoes. They say the answer is 2. Okay? Y'all agree with 2?
Is that because they're counting pants as only 3 parts and not 4?
We looked at that as well, and counted them as 3. But if you counted it as 3, it would still kind of be roughly the same. 2 out of 3 versus 3 out of 4 is still 70-ish%. Not a whole lot of difference as far as making a difference between the 2.
Well, it sounds like they're taking the stockings, and if she had done everything independently except the stockings, she could have been at 5.
Right.
Because she needed the extra help in addition to the pants, they took it down a number.
I agree with you. Totally. So there's always room for a little bit of argument and problem solving.
So say that dressing is not necessarily part of our treatment as like physical therapy, but they want to put on pants before we go down to the gym.
Yeah,
Would I still need to score that? Or-
absolutely.
Yes? Okay.
Yeah. And so that's why it's so important to kind of know how to score everything. So I say everybody scores everything with a couple of little caveats, and here they are. My nurses, or when I say nursing, I mean nursing staff, CNAs included, okay? So if you do not allow a patient to walk as far as they can possibly walk, so around the nurse's station, up the hall, if that's what they want, do not score walking. Same thing with stairs. I can't think of a reason why you would take somebody upstairs, but you know, if for some reason it came up, normally we say nursing doesn't score locomotion or stairs. If you take them to the bathroom and that's as far as they can possibly walk, fine, score it. Some of my facilities have walking programs that they do on Saturday and Sunday so that the patient gets up and does some things, and nursing is responsible for that. So if you have a walking program and you're walking folks, that's different. And if they're walking as far as they can, score it. But that's like the main things. And then also don't score it if you didn't allow them to do it as independently as possible because of time constraints. Okay, so toileting has 3 parts. Pants down, wipe your bottom, pants up. Simple as that. The only other things that come into play with toileting is, do you need to hold on to something to maintain your balance to pull your pants up or down? So that's where the assist comes in. So how many parts in eating? 3. Bathing? 10. Grooming?
4.
Got it? All right. So transfers. Here's what you need to know about transfers. They must start and end in supine position if you're doing a bed transfer, okay? So you walk in the room, Mr. Smith's sitting there in bed, the head of his bed's at 40 degrees, and you say to Mr. Smith, "Hey there, I'm Haley from therapy, and we're going to transfer you out of that bed, but we need to lay the head of your bed all the way down before we start." Now, once again, do no harm. Sometimes, rarely, that'll be contraindicated. If there's any kind of head injury, sometimes they don't want the head below a certain degree. If that's the case, then monitor and adjust. But for the most part, you don't want that patient going home to a standard bed and not being able to go from supine to sit. We need to test that. And we need to treat it. And the same thing with the fall to the floor. I try to get my therapists always put that patient on a thick mat in the floor and let's teach them how to get up from it. Anybody in here remember when the last time they fell was? I do too. And it hadn't been too long ago. It was fresh on my memory, right? And I told them today, the older you are, the more you're going to remember when the last time you fell. Because the older you get, the harder it is on your body. And it's harder to get up and recover from. So those are just some transfer kind of things. If you're helping a patient in or out of bed and you have to move one limb into the bed, so they got that one leg, they can't get in there. So if you're moving that one leg, it's a 4. If you're having to move both feet up into the bed, it's a 3. And you're going to think about the lifting the limbs as components for that. You're also going to talk about setup. If you're moving the footrest, if you're positioning a sliding board, those are your setup. And so if you're touching them, it's just steadying assistance. They're able to do it, but you've got your hand on their gait belt or on their back so that they can go from one surface to another. But if you're lifting, you know what I'm talking about. You're engaging your muscles to pull them up. If you're doing the lifting portion, it's a 3. But if you're lifting and lowering that patient so they don't flop down because they're so fatigued, then that's a 2. And so you need to capture the burden of care. And remember, lifting and lowering is a 2, but lifting or lowering is a 3. Okay? So here's the scenario. Transfer bed, chair, wheelchair. Hope needs guiding assistance from a helper to go from supine position to sitting on the side of bed. The helper then provides contact guard assistance to complete the rest of Hope's transfer to her wheelchair. What's her FIM rating? So my big question was guiding assistance. What exactly does that mean? Well, you're guiding them.
Are you with your hands on them and you're not engaged?
Right, so you're touching them, right? Yeah. So if you touch, it's a 4. Yeah. Now, if you engage your muscles, it'd be a 3. But we're thinking a 4. Okay? So toilet transfers. So you're With a 7, a patient approaches and sits down on the toilet, gets up from a standard toilet independently and safely. That's what a 7 looks like. In a wheelchair, they take care of everything. They might be able to independently remove the arm if it's a raised arm or drop arm. They can do their leg rests. They can do everything they need for a pivot, standing pivot transfer without a board. That would be a 7. If they use a board, then it would be a 6. If a person is needed for moving all of their footrests and everything, then that would be a 5. If they require touching for the sliding board positioning and that kind of thing, then that would be a 4. And if you're lifting or lowering that patient, it would be a 3. If you're lifting and lowering, it would be a 2. And if it takes 2 people, it's always a 1. So we talked about function modifiers for tub and shower. OT selects whether it's going to be a tub or a shower, and that's how we score that. If it's supervision, it's going to be moving footrest, position, sliding board, just like the last transfer we talked about. If you're just steadying, you're barely touching them, it's like contact guard is 4. If you are lifting or lowering, it's a 3. If you're doing both, it's a 2. If it takes 2 people, it's a 1. Clear as mud. Got it? Okay. So we talked about walking wheelchair and about how the distance factors into it. So what does locomotion mean? It can be walk or wheelchair or both. PT is typically the one in most scenarios that decide, are they going to be a walk, a wheelchair, or both. So we're going to talk about how far they traveled, amount of assistance that they required, and household ambulation exception. So if they can walk 50 feet or roll 50 feet in a wheelchair, and they're discharging home independently, then they can score a little bit higher because of the household exception. That's what the exception means. So we're going to talk about that. So traditionally, we've got 150, 50 to 149, and less than 50. So that's what we've already talked about. But when we're talking about those exceptions, we're going to talk about 50 feet, they can go and still score a 5. But that's only if they're discharging home and they can do it without the assistance of another person. So that's the only exception, and it does count for wheelchair and walk, either one. There's also a household exception for stairs. I'll go over it in a second. So to be a 6, they have to operate their manual or motorized chair independently, minimum 150 feet, turn around, maneuver around the chairs and tables. But they also have to negotiate a 3-degree grade ramp. PTs earlier today said you guys do have a ramp that you use with your patients. That's good. So a minimum of 50 feet will get you a 5 only if it's household exception. Otherwise, it's no higher than a 2. And then a total assist is the assistance of 2 people or wheels less than 50 feet. So the PT is going to establish whether or not it's what the most frequent means of locomotion is going to be. Are they going to be walk or wheelchair or both? So the professional judgment is kind of what they look at with that. What were they before this event happened, and what are they now? And were they using an assistive device before, and are they now? So this is another takeaway. If you're an evaluating therapist, OT-PT speech, before you issue equipment of any kind, you need to score that patient. We compare it to a doctor prescribing medicine before they evaluate the patient. You wouldn't put somebody on blood pressure medicine if you didn't take their blood pressure and make sure that it was high to begin with. So don't give someone a dressing stick or don't give someone a walker until you've assessed their locomotion. So you want to do it compared to what their prior level of function was. What were they doing at home before they came here? If they were grooming, standing up at the sink, and looking at themselves in the mirror, then you need to assess them that way, unless do no harm is medically contraindicated. So if they're not weight bearing on a lower extremity, you're not gonna have them try to stand up at the sink to do their grooming. But otherwise, you're going to, if it's just weakness that we're dealing with. Stairs, it's going up and down a flight of stairs, 12 to 14 steps. We recommend many times, if you feel it's safe, to use your facility stairs. Some of our facility stairs are just right, and some have different height steps that many people don't feel are appropriate. I'm not familiar with your stairwell here, but if you don't have 12 to 14 steps to traverse, then that's a good way to get them. And it's most important whenever a patient has steps when they get home. So this is the exception, household ambulation at level 5. If they can go up and down 4 to 6 stairs independently, they can use their device, cane, walker, or a rail, then they can score a 5. But otherwise, it's going to be lower. So recap, the takeaways are a patient can change throughout the day. Just because you scored them a 4 this morning doesn't mean this afternoon they may be a 2. It's vital to capture a picture of that patient 24/7. We want to get an accurate depiction of what that patient's like around the clock, because we're not just here 3 hours, we're here 24. And we also cannot use a 0 for bladder or bowel management or cognitive items. 0 cannot be used just because you didn't observe the patient doing the task. And timeliness of scoring is critical. So if you're here for a 12-hour shift, an 8-hour shift, you witnessed something early this morning at 7 or 8 o'clock at night, in the morning, and at night you do your note, and can you remember all that stuff? You know, some of it you will remember if it was in an episode of care of some sort, but you may need a scratch sheet of some kind to jot some things down to keep track of some of your notes, just a log or something. The quicker you write it down or type it in, the more accurate it's going to be. And then your documentation must support your scoring. So if you just assign a score and then your words tell a different story, that number doesn't count. So your words need to support the number that's assigned. And I know that a lot of your documentation may be a little different as far as some of my sites just actually put a number in a blank rather than some of the structure that you guys have on your documentation system. But certainly you need to make sure everything aligns when you're doing your documentation. So I've got a couple of FIM questions to go through, and then we're out of here. Six. All right. So I think I said this earlier, but I'll tell you now that UDS does not publish any part, that's the company that does the credentialing test that we have to take. So they don't publish their questions. So many times, some of you guys will be taking a test and it'll tell you that you got a question wrong, and you read over it again and you're like, I don't see it. They'll like type it out or send me a screenshot of it and say, what's the answer to this? What do you think? So then I read over it, and when they do that, I start putting it like in a little bank. And so that's how we get access to any of the questions, but they don't give us access. So if they did, we'd probably say, here's the questions, and study these. But so this is just a small glimpse. It's not even close to all of the questions that are in there. And every test is different. You may get some of these questions, but you're not going to have them all. All right, so we've already done the Samantha question. We did Tony suffered from a stroke, and we did his bathing. Let's see. Here's one. Kim adjusts her dress and underwear and cleans herself. Just a second. All right. Can you guys see that? I need to make it bigger.
Bigger.
Okay. When you think you know the score, right up in front of you, give me how many in you. Okay. So Kim adjusts her underwear and her dress, cleans herself after urinate, pulls her underwear back up, supervision from a nurse. There's the word supervision. 5. Yeah. So, told you, they're sneaky, they're tricky. They slip in that setup supervision, they put it in an obscure place and you don't catch it. So if you're looking, look at what are we scoring, toileting, and your mind says pants down, pants up, wipe your bottom, but always look for setup supervision. Okay, so it's a 5. If it didn't have that word supervision in there, it would be a 6 because of the grad bar. So you're right on target. So Jacob's on bed rest and has not completed a transfer. What's his FIM rating for transfers? Big fat 0, right? You didn't do it, and that's the one reason why it's okay to give a 0. One of 3 reasons. Amy becomes short of breath while climbing the stairs with therapy and uses oxygen. A helper carries Amy's oxygen while Amy goes up and down 12 steps. What's Amy's FIM rating for locomotion of stairs? I'm sorry, I'm moving that while you're moving that. Okay, up top. So what are we scoring? What's the category? Stairs. What do we know about stairs? How many steps does she have to go up and down? 12 to 14. And she went up 12, right? So she's in the ballpark. Anybody help her? Yes.
She's set up, help her set up.
You what?
She's set up, isn't she?
Set up.
For someone carrying.
So that would be like set up supervision 5. Nobody touched her, right? She's not a 4. Discussion? It is a 5. And what elicited discussion for us as a team was forever, we've been told, if you're walking a patient down the hall and you've got their gait belt and it requires someone else to push the wheelchair or oxygen behind it, you gotta count it as assistance of 2. Y'all ever heard that? So that was what kind of had us off, because we had always been taught that. But in this case, they say supervision. Okay? All right. Jenny's been a patient in rehab for 2 days. She wears a mini pad in her underwear due to stress incontinence. She had 3 accidents in the acute care hospital 2 days prior to her discharge to rehab. Since coming to the rehab unit, however, she's not had any accidents. Jenny changed her own mini pad from a supply she keeps in the bathroom. What is her FIM rating for bladder management? So remember that there's 2 parts to bladder management. There's level of assistance and number of accidents. So if you had to say what's her level of assistance, what would that be? Yeah, we would say it is a 6 because she is wearing a collection device, or, you know, she's wearing a pad, but she's taking care of all that herself, right? No burden of care on anyone. But with the look back period of the 7 days, it does say that she did have 3 accidents, right? So let's look at that little chart again. Not as kind of fuzzy looking here. But whenever you look at 3 accidents, it makes it a 3. And so she's a 6 as far as level of assistance, but she's a 3 in number of accidents. You've got to take the lower of the 2. So what does that make her? Yeah, so she's a 3.
What if somebody's completely incontinent and was completely incontinent before their hospitalization?
Good question. You still have to score what you see. So you're counting the number of accidents that they have. It's probably gonna, depending on how well their brief works or whatever, it's probably gonna make quite a few accidents there. You're gonna keep up with that. But yeah, even if the prior level of function was pretty low, you still count it.
And accidents are considered if clothing or linens are soiled.
Right.
Okay.
It also counts, let's say someone doesn't put the lid on the urinal and they knock it off and you have to mop the floor. That would be an accident as well.
Or if, like, when they're changing themselves, if they're getting their clothes soiled, it's contained until they're trying to manage it themselves.
That's right. You got it. I did get an email with a question about they had a brief on and they went to the bathroom and they got feces on the toilet seat whenever they were trying to change themselves. Is that an accident? The answer to that was it depends on how much burden of care it is. Like if it's just barely on there, then it's really not that big of a burden because in cleaning you're gonna like clean it up. But if it's enough that it's a burden, then certainly you're gonna count that as an accident. So that's the professional judgment again. You never thought you'd get down to the point that you were analyzing whether it was an accident or not, but that's what they want you to do. Hope needs guiding assistance. That was another one of the things that we did earlier. And so they're going to formulate the questions in ways that you're looking for anything that indicates assistance. And this one was a pretty good one. Richard uses a wheelchair that he propels 60 feet immediately. So he hops in it and goes 60 feet. Richard has COPD and needs oxygen, which a helper carries when he walks 15 feet. Richard has used a wheelchair for the past 5 years and is expected to continue to use it after discharge. What's his FIM rating for locomotion, walk/wheelchair? So we're scoring the locomotion, walk, wheelchair, but are we scoring walk or are we scoring wheelchair or both? Who thinks we're scoring walk? Who thinks wheelchair? Okay, who thinks both? Okay, we are scoring wheelchair. Why? Prior level of function. So prior level of function, it was wheelchair, we're scoring wheelchair, he hops in it and goes 60 feet independently, immediately. So what do you think, what are we scoring it? What's his FIM?
Discharging home?
Huh?
Is he discharging home?
Yes. He's a 5. It's a household exception. He can do it independently. He's in his chair. He can only go 50, or a little over 50 feet. If he got up to 150 feet, he'd be a legit 6, you know, but because he's just going that 50 feet, it qualifies him for a household exception. All right, that's all my sample questions. I'm ready for, if you guys have any questions, I'm here to answer. Also, if you have any FIM questions that come up over time, get those to Mallory and she'll forward that to myself. If I don't know the answer, or even if I think I know the answer, I usually put it out for our team. There's 6 of us across the country, and we analyze everything. If we don't know, we send it on up to CMS to get a second opinion or a third opinion. All right. Yes, ma'am.
Scoring wheelchair.
Yes.
You have to score turning and a ramp and locks and brakes and footrests and armrests. Anything that the patient needs to handle. How do you do that? I mean, I guess I don't know the question, because all those scores are based on distance, right? So what if they can travel 150 feet? That's after I put the leg rest back on them for them.
Okay. So that would be like you doing setup for them, and then they're able to do the task. So that would be a 5.
What if I only did the leg rest, but they did the armrest and the locks? Is that?
It would still be a 5, captures the burden of care.
It's all just set up. I need,
Yeah.
now all of those components together is still just set up?
That's right. Kind of counterintuitive, I understand, but certainly it is.
What if they go 150 feet but can't do a ramp?
There's not really a breakdown, even though it says that that's part of the navigation and that kind of thing. It does not clearly delineate exactly what parts make assistance. So then you're going to look at your burden of care. I'd also have some sort of consideration for what they have at home. If they're permanently in a wheelchair, or at least for the time being, they're going to have a ramp of some kind. Do they have anyone to help them get up the ramp at home?
What if they don't have a ramp at home, but they can't do 2 steps into the house?
Are they going to be walker or wheelchair?
Well, if they're using a wheelchair to move, but they can do the 2 steps.
Do you have somebody to hoist that wheelchair up in their house and then get her?
Well, sure, yeah, probably.
Okay. So burden of care. What's the burden?
And they didn't touch the patient, they just took some steps.
That's right. And that's exactly how you have to talk it out. And I won't be here to talk it out with you. I'll be happy to if you call me, but depend on each other to talk it out, because that's how you figure it out. The first barrier is going to be passing this credentialing test, but really, I mean, that's only a small component of what you're really learning. What you're really learning is how to help your patient. And so talk it out with the people that know best, and that's these people here. You have a question?
I've never taken the test before, I'm new.
Okay.
When I take the test, I have something I can refer to?
Absolutely.
Help me? Well, where do I get that?
So when you, I can't pull it up because it'll deactivate. Once you log in, you only have a certain number of days to finish it and take it. But you'll log in, so everybody has a unique ID, and I use that. All of your information is here in the top. So you'll go to this website, you'll put in our facility code, MP65, you put in your code, and then it will show you. It says, here are some resources for you to use. It gives you like a little source. There's like 5 different resources that you can pull up mid-test. So it's open book, but every test is different. So like if we wanted to take the test right now as a group, we wouldn't have to take it 20 different times because all of the questions are different. And then if you fail it, then you have to get a new code. It'll ask you for your name. So once you pass it, will override your fail. But you'll see, you can't miss the resources. There are about 5 different
So
things.
these resources, I should print them out so I have them?
No, you'll just scroll through them.
Don't we have cheat codes still on the unit?
Apparently there are, but you have to ask people who are on the
I just
unit.
think that's been a long time.
Yeah, I've never seen any down there, but I will also send you Monica's presentation. But a lot of people are just taking the test today before I figure that out.
Yeah, absolutely. You'll have a handout of everything here, and then I'll also send you the copies of those cards, so you'll have them on like presentation. It looks just like those cards, except it's just on paper. And then you'll also have a lot of reference kind of stuff from me. It'll be easy
When do we
to
get that?
email. How do you get it?
Her presentation?
Yeah.
Did you ever send?
I will today.
Yeah, I'll send it out tonight.
Everybody got a facility email? Do you have a facility email already? Yeah.
Just your old Anderson email.
So by tomorrow, you'll have that in your.
Can I print it off from that email?
Mm-hmm.
Yeah.
Yeah.
I'll send you the presentation in handout format. That way it doesn't take up 70 pages or whatever. Okay? Yes, ma'am.
About how long does the test take? It was to know where everyone.
Probably, I would say give yourself like 25 minutes, anywhere between like 15 and 20 minutes.
Yeah. Some people, it has taken longer than, a little bit longer than that. Just depends on your reading speed and how long it takes you to process it.
But you said there's resources right there, pull out.
Right.
How
No,
many
it's not
questions?
fast.
How many questions?
There's 10 pages, 20 questions.
Yes.
Can you stop and start?
You can, but it'll tell you, when you log in, initially it'll tell you kind of the rules, and I think you have 5 days from the first time you log in.
And that keeps the same test up and running.
Right.
You go over 5, you have to have a new login.
Yeah.
All the modifiers and stuff that you pulled up, all that fit in the resources.
Mm-hmm.
If you don't come back in 5 days, does it start a fail?
Yeah.
First one's a fail then,
I think it's considered a board or something like that.
but it's a fail.
Yeah, you need a new code.
What score do you need to pass?
80%. And so for Anderson to be a credentialed facility, which is what we're going for, 80% of the people that take it have to score 80% or above.
But we will expect everyone to keep taking it until they pass here.
And you can pass, for sure. Everybody's like,
Okay.
I know it's not the most riveting material at this time of the evening, but I thank you for your attention and not going to sleep.